Hello, everybody. I'm going to talk about non-steroidal anti-inflammatory drug hypersensitivity diagnostic and make a focus on drug provocation test. Well, before going into details in the subject, I'd like to remind you that non-steroidal anti-inflammatory drugs can be classified with different classifications. The most common is the pharmacological subclass, in which the different non-steroidal anti-inflammatory drugs are sorted out according to their power on cyclooxygenase 1 and 2. But the classification that interests most allergists is the chemical classification. Indeed, we can classify non-steroidal anti-inflammatory drugs into 8 to 10 different chemical classes, as shown on this slide. And this is important because when an allergy mechanism is involved, what the immune system recognizes is forms that are the same if one non-steroidal anti-inflammatory drug belong to the same chemical class. Well, this is a very frequent reason for consulting an allergist. In our database that comprises more than 12,000 patients, it's actually the second reasons for consultation. As you can see on the left-hand side, the first reason is beta-lactam, suspicions of allergy, and the second reason is non-steroidal anti-inflammatory drug. On the right-hand side, you can see how many patients in the end have actually hypersensitivity to the drug, which is 15.2% in our database. Another point that we need to stress before going into details is the mechanisms. Non-steroidal anti-inflammatory drugs can give rise to allergic symptoms through two different mechanisms. The first one is non-allergic on the left-hand side by perturbation of the arachidonic acid metabolism. And the second one is a true allergic mechanism, whether type 1, IgE dependent, as has been shown with pyrazolones mainly, but with some others, and also type 4, T-dependent mechanisms. Well, for the non-allergic hypersensitivity mechanism, it is nice to show that kind of data. As you know, phospholipase A2 actually acts on nuclear membrane phospholipids and liberate arachidonic acid and platelet activating factor. And this arachidonic acid is further down taken by different enzymes, including cyclooxygenase, leading to prostaglandin and thromboxane on one side, and lipooxygenase leading to leukotriene and heat compounds. As you know, non-steroidal anti-inflammatory drugs, including aspirin, actually inhibit cyclooxygenase, pushing the whole metabolism towards leukotriene and heat formation and decreasing prostaglandin and thromboxane formation. This is particularly the case for aspirin that acts on both cyclooxygenase type 1 and 2 with a major reduction of prostaglandin E2. Well, there are different forms of hypersensitivity to non-steroidal anti-inflammatory drugs. Most of the forms are in the skin, as you can see here from left hand to right: urticaria, angioedema, fixed drug eruption, toxic epidermal necrolysis, Lyell syndrome. So these are the skin eruptions that can be seen with such reactions. Vasculitis is possible, as well as specific organ involvement. Clinical presentations for adults and children are quite the same. Regarding the different phenotypes of non-steroidal anti-inflammatory drug hypersensitivity, the European Network for Drug Allergy has classified them into 5 different phenotypes, as shown here, but I will go into more details. The first one is non-steroidal anti-inflammatory drug exacerbated respiratory disease, the classical aspirin-induced asthma. The second one is non-steroidal anti-inflammatory drug exacerbated cutaneous disease. The third one is NSAID-induced urticaria angioedema. And the first three are related to COX-1 inhibition. And the last two are actually of allergic mechanism. The first one, IgE, single NSAID-induced urticaria angioedema or anaphylaxis. And finally, NSAID-induced delayed reactions. The clinical presentation varies, as I said, but at the acute phase, one needs to quickly think about the possibility of a drug hypersensitivity, detail the type of lesions, and we know that in drug allergy, polymorphism is frequent. Take photo. We have trained now doctors to take photos, even patients, in order to be able to make remote diagnosis. We need to look for organ involvement, in particular liver enzyme, blood counts, and renal parameters, in order to see whether or not there are danger symptoms and signs. Chronology is very important, whether the reaction is acute or delayed after the last drug intake. We need to eliminate several differential diagnoses and evaluate risk factors. Regarding NSAID, risk factors are severity of the initial reaction and the comorbidities. And regarding comorbidities, there are comorbidities that are of special interest regarding NSAID: asthma, chronic rhinosinusitis with or without nasal polyposis, and chronic spontaneous urticaria are of special interest. Let us go now into details. As always, for drug allergy, the strategy starts with the clinical history, may then lead to skin tests, sometimes some biological tests, and finally, in some cases, drug provocation tests. Well, we know that in clinical practice, the clinical history is very important to take. And this process has been standardized. There are questionnaires translated into many different languages that help the clinician to pick up the clinical history. We know that the clinical history doesn't have 100% positive predictive value. That is why we need a drug allergy workup, starting with skin tests. They are standardized by different groups all over the world. And of course, they are only important when an allergic mechanism is involved. And in the case of non-steroidal anti-inflammatory drug, they are rarely positive because most of the cases are non-allergic hypersensitivities. We need to read it immediately using prick test and intradermal test if the clinic is anaphylactic, or to read it non-immediately, have a delayed reading with delayed reading intradermal test or patch test otherwise. In many cases, drug provocation tests are needed. They are standardized by different groups all over the world. They are officially the gold standard, and they are performed in more and more centers, and I will focus on drug provocation tests a little bit. When I say drug provocation tests, I am actually thinking about provocation with the suspected drug to demonstrate. And I am not talking about looking for an alternative or forcing the body to tolerate the drug. The indications in clinical practice varies according to the clinical forms, according to the phenotype that I showed previously. If the presentation is mainly respiratory, the practice have showed us that the provocation in clinical practice is rarely needed because the predictive value of the clinical history is quite high. I'm thinking about an asthmatic patient that would exacerbate several times after taking aspirin. There is no overdiagnostic that NSAID-induced asthma. For those respiratory forms, we mostly use drug provocation tests in order to find an alternative NSAID, and most of the cases are COX-2 selective inhibitors. if we do provocation tests, they are standardized for oral, bronchial, and nasal provocations. In non-respiratory forms, drug provocation tests are often needed to confirm the diagnosis, especially if there are doubts and of course, if there are no contraindications, which I will detail later on. But they are also needed to find alternatives. They have to be integrated into a stepwise approach after due consideration, only if other less dangerous methods are not available or inconclusive. They really need to address the future needs of the patient. They have to be performed under the highest safety conditions and respect the following contraindications, all the severe form that we cannot control if we re-induce them. They have long been empirical protocols with different doses, starting from point-something% of the therapeutic dose up to the therapeutic dose. Recently, thanks to our big database, we could reanalyze our positive provocation test by survival analysis using Kaplan-Meier test and deciles of reactive dose in both paracetamol provocation tests. Paracetamol is actually a non-steroidal anti-inflammatory drug, and also in more than 300 NSAID positive protocols patients. And these are the empirical dose protocols that we've been using for the past 25 years. These doses are given every 30 minutes for both adults and children. The difference between adults and children is that the final dose for children is calculated according to the weight of the patient. Doing so for paracetamol, so we had almost 500 patients with a suspicion of paracetamol allergy, and in the end 55 were positive. We could analyze using Kaplan-Meier that kind of when the patient reacted. As you can see here, you have on the x-axis the reactive dose. You see 0% of the total dose up to 100% of the total dose, and on the y-axis you can see the proportion of positive patients in the end. Of course, in the end 100% of the patients are positive because we are testing the 55 positive patients, and you can see that after every accident, that is where most of the patients react. Analyzing these different steps that are called deciles in statistics, we could skip a few steps and we could concentrate on the major steps. That's how we change our protocol for 20%, 30%, 50% of the therapeutic dose every hour, and not every 30 minutes as we did at the beginning. We did the same exercise with more than 300 positive NSAID patients, and details of the patient on the left-hand side are not really needed, both adults and children, different clinical presentation. And we found that kind of curves. We tried to group the NSAID according to their chemical structure, didn't work. We tried to group the NSAIDs according to the pharmacological classes, didn't work. What worked very well is grouping the NSAIDs according to their pharmacodynamic classification, which I didn't talk about. We know that there are rapid onset NSAIDs, slow onset NSAIDs, and NSAIDs that have moderate absorption that act in the middle. And that was interesting to find that we could actually use this classification in order to group our patient. And doing so and analyzing in details the different deciles, which I am not going into detail, we could simplify our protocol. For example, for slow absorption NSAID, like piroxicam, we now use 25% of the therapeutic dose, and 3 hours after, 3 hours, because the absorption is slow, 75% of the therapeutic dose. For moderate absorption drugs, you can see the now the different steps. And for rapid absorption drugs, you can see that now we are using 3 steps as for paracetamol, but every 30 minutes. This is all details in our allergy paper that is in press right now. All the details how we could go from empirical to data driven drug provocation tests. Another question that we addressed some years ago was the negative predictive value of a drug provocation test. In more than 400 patients that had a negative provocation, that had a suspicion, but then a negative NSAID provocation, we recontacted those patients and we asked them, have you taken your NSAID again? 70% yes, took the NSAID again, and have you reacted again? 8 actually reacted. We called them again and tested them. Amongst 8, only 3 came back, had another provocation. 2 were negative, 1 was positive, but in between that patient developed chronic spontaneous urticaria, which in the end gives us a negative predictive value of 98.6%, which is very good. When a provocation is negative, we can reassure the patient and say that the likelihood that he or she is going to react in the future is very unlikely. So having that in mind, that the diagnosis is mostly centered around drug provocation tests, how can we organize the diagnosis and find the proper phenotype? As I said in the beginning, by analyzing the chronology, acute versus delayed, the clinical presentation, respiratory versus skin versus others, we need to look for those specific underlying disease that I talked about: asthma, chronic rhinosinusitis with or without nasal polyposis, and chronic spontaneous urticaria. We need to check reactions to other chemically non-related NSAIDs. And having those parameters in mind, which I drew here on this slide, starting with acute, less than 1 day after the last drug intake, usually very quick, whether it's respiratory on the left-hand side or cutaneous on the right-hand side, whether there is or there is non-underlying disease, whether there is or there is no cross-reactivity, you can diagnose NSAID exacerbated respiratory disease, NSAID exacerbated cutaneous disease, NSAID induced urticaria and angioedema, and the single NSAID induced urticaria, angioedema, and or anaphylaxis for the immediate reactions. For the non-immediate, you have the special clinical presentation, no underlying chronic disease, no cross-reaction. And for those last 2, that's where skin tests are useful. Skin tests are not useful for the first 3 phenotypes. I haven't talked about biological tests because they are still under exploration, but mostly the basophil activation test could be of interest. To conclude, after this long presentation on diagnosis, how do you manage? Well, mostly by avoidance. That is why it's important to have a firm diagnostic to start, because avoiding for life all NSAID is quite detrimental for a patient. So this attitude is always needed until the drug allergy process, and then the patient has a drug allergy pass issued. We need to treat the possible underlying chronic disease, of course, but thanks to drug provocation test, we can also look for alternatives that are mostly coxibs for NSAID-induced exacerbated respiratory disease, but other class of NSAID for other forms of NSAID hypersensitivity. Finally, in most of the patients, and that is the information that we give them, regarding aspirin, it is always possible to induce tolerance for aspirin if one day a cardiovascular indication occurs. Thank you for your attention.
I would like to now invite Professor Thong to give his talk.
Okay, hi, hello everyone. So today I'm going to talk about the topic of delabeling drug allergy and what some of the practical considerations are. So in the overview for this talk, I'll go to talk a little bit about the classification of adverse drug reactions, drug hypersensitivity reactions, and what constitute the serious drug hypersensitivity reactions. In particular, anaphylaxis, the severe cutaneous adverse reactions like SJS, TEN, and drug rash with eosinophilia and systemic symptoms. A little bit about why delabeling is important in certain situations. But before doing that, our analysis of the risk-benefit assessment, who should be authorized to delabel the drug allergy or adverse drug reaction, how to delabel it, and how to prevent further mislabeling, which is probably the most important step of all. So in the classification of adverse drug reactions, the WHO definition defines an adverse drug reaction as a response to a drug which is noxious and unintended. And this usually occurs at doses which are normally used for prophylaxis, diagnosis, or treatment of particular disease or condition, or for the modification of physiological function. So broadly, the ADRs are classified into the type A to E ADRs, and in particular, the drug hypersensitivity reactions are defined as type B adverse drug reactions. And we do know that adverse drug reactions occur in 3 to 6% of all hospital admissions and up to about 15% of hospitalized patients. So this is a table which shows you the type A to type E adverse drug reactions and what each are defined as. And what we want to focus a little bit more on today will be the type B so-called bizarre adverse drug reactions, which are unrelated to pharmacological action, which are dose independent and usually fairly unpredictable. And we'll focus a little bit more in particular on the drug hypersensitivity reactions. But when we talk about delabeling a patient or mislabeling a patient with a drug allergy, most times you will find that some patients have self-labeled or have been inadvertently labeled as being drug allergic when what they actually had during the index reaction was more an adverse drug reaction. So say, for example, pedal edema from calcium channel blockers. So this is a paper which has been published in the 2019 issue of Allergy, which gives you a very good review of the mechanisms of drug hypersensitivity reactions. And we do know that when we talk about the allergic drug reactions, most of them are mediated either through IgE or non-IgE mediated mechanisms, and in particular T-cell mediated mechanisms. The long-held theories and hypotheses of the Hapton hypothesis and the PI concept, which is one of the main mechanisms which mediate the allergic drug hypersensitivity reactions. And what we use to classify as non-allergic drug hypersensitivity, where I think in the last 2 to 5 years or so, there has been a resurgence in the interest in using this term pseudo-allergic reactions, which are usually a little bit more immediate. And it also includes the NSAID hypersensitivity reactions of urticaria, angioedema, anaphylaxis, which look like allergic drug reactions, but in truth are mostly mediated by leukotriene production. So in the evaluation of any drug hypersensitivity reaction, I think we do need to be pretty careful of the serious reactions, because before we delabel a patient to a reaction, we do need to be pretty sure that what they had in the initial episode was not something serious or severe, which could potentially recur if they were re-exposed to the drug. So when we look at drug-induced anaphylaxis, we do know that looking at most of the epidemiological cohort studies from the United States, Europe, and Latin America, up to 20 to 40% of these are caused by drugs. And drug-induced anaphylaxis is much more common among adults than children. In terms of the severe cutaneous adverse reactions, the reactions which fall into this category mainly comprise Stevens-Johnson syndrome, toxic epidermal necrolysis, and the drug rash with eosinophilia and systemic symptoms. But of course, SJS and TEN does tend to highlight a little bit more in the literature, and that's because these are associated with a very high risk of mortality and morbidity. If you look at the data from the UDRA vigilance cohort, the fatality of SJS, overlap SJS, TEN, and TEN are respectively in the regions of 7%, 12%, and 22.4%. So it's fairly important to be able to recognize these reactions early and to stop the culprit or the suspected drug. And when we look at the literature for risk factors for drug allergy, we do know that there are associations with certain patient-related risk factors, like, for example, age, being female, polypharmacy, and comorbidities. And in particular, in the area of severe cutaneous adverse reactions, there is a lot of literature on ethnicity and HLA genotypes, in particular for SCAR. So this is a nice review which shows the common drugs which cause drug-induced anaphylaxis. And it's no surprise that among adults and children, most of the literature centers around the usual culprit drugs, which are antibiotics, non-steroidal anti-inflammatory drugs, and in particular in adults in the perioperative setting, neuromuscular blocking agents, antibiotics, and surgical dyes. Among children or adults, analgesics like NSAIDs figure a little bit more prominently, followed by antibiotics, and in particular, these would include the cephalosporins and the beta-lactam penicillins. There are certain regional peculiarities. For example, if you look at some of the literature arising from our region in China, traditional Chinese medicines can sometimes also be an important cause of anaphylactic reactions. And in our region in Southeast Asia, it's not uncommonly that sometimes you do find that patients get their hands on traditional or alternative medications, which may sometimes be contaminated with active ingredients of Western products. And these themselves can also induce drug-induced anaphylaxis. So again, in the 2019 review paper in Allergy, this is a nice table which shows you all the up-to-date HLA genotypes associated with the various severe cutaneous adverse reactions, in particular SJS and TEN. And in the Asia-Pacific region, the important drugs to always think about would be carbamazepine, associated with HLA B1502, allopurinol, associated with HLA 5801, and abacavir, associated with HLA B5701. And I think why it's important to know this list of drugs is because if in any patient who has reported in the list of drugs that the patient is presumably allergic to, if any of these high-risk SCAR-associated drugs are implicated, I think one needs to be very careful before thinking about whether the initial index reaction was truly genuine or not, and whether or not it is safe to even delabel these drugs from the patient's list of drug allergies. So when did this concept of delabeling come about? It's been almost a decade, where in 2010, it was shown in small studies that the first direct challenge among children with benign non-immediate reactions to penicillin without preceding with skin testing seemed to be fairly well tolerated. And we know that probably in children in particular and adolescents, most times they are labeled as being allergic to a NSAID or a beta-lactam penicillin, usually because these drugs are given concomitantly during an acute viral infection. And so the reaction which the patient had may have been just an acute viral urticaria or a viral exanthum. So it's not surprising that among children, most times, by and large, the so-called label of drug allergies may not be true. In 2012, there were early reports of the impact of penicillin labels on antimicrobial stewardship. And in 2013, that was when the first reports of this terminology called penicillin allergy delabeling arose. So in the next 4 years, between 2014 to 2018, there were lots of studies which tried to show the impact of penicillin labels on certain infections, for example, Clostridium difficile associated diarrhea. And then there was thus a recognition of the need to address penicillin allergy, again, mainly something which was fronted a lot by the infectious diseases community. So this was brought about by guidelines which arose from the CDC as well as the Infectious Diseases Society of America on the role of perhaps having various programs to delabel a penicillin allergy as part of an antimicrobial stewardship projects. So in 2016 to 2018, there were more recent articles on penicillin and cephalosporin cross-reactivity, which highlighted what we probably didn't know in the 1990s or the early 2000s, that specific R1 cross-reactive patterns and very low rates of cross-reactivity based on beta-lactam ring was actually the truth behind this so-called penicillin and cephalosporin cross-reactivity. I think in the late 1980s and 1990s, there was a lot of literature which seemed to suggest that beta-lactam cross-reactivity was mainly mediated by the beta-lactam ring. Up to about 5 to 10% of patients with beta-lactam penicillins IgE-mediated reactions were supposedly at an increased risk of developing cross-reactive reactions with cephalosporins, in particular the first generation ones like cephalosporin and cephalotin. But now we know that a lot of cephalosporin-induced reactions are mainly side chain mediated rather than beta-lactam ring mediated. And I think because of this newfound knowledge, there was even a greater impetus then to think about whether patients who were labeled with penicillin allergy were truly penicillin allergic in the first place, and whether it was safe enough for them to be given a cephalosporin or in fact even a carbapenem. So a lot of people always ask me, how do I remember exactly which R side chain goes to which beta-lactam penicillin and which one belongs to which cephalosporin and which are the cross-reactivities? So I think there are lots of tables out there. This is one which is published this year in Allergy, a review paper by Stone et al., which gives you pretty good charts, which are useful even in a day-to-day clinic setting to help you to decide what are the risks of cross-reactivity in terms of the structures in the penicillin moiety as well as the cephalosporin moiety. So these things don't really need to be committed to memory. And I think also it is a reflection of what are the types of penicillins and cephalosporins that are available in the market, in the hospital, and in the country. So there would be certain types of penicillins and certain types of cephalosporins which should not be routinely used, for example, in a primary care setting or in any acute hospital. So say, for instance, cefoxitin is a cephalosporin which is available but usually used only to treat very specific infections, for example, atypical mycobacterial infections. And other drugs like, say, aztreonam, for instance, and cefepime would not be drugs which are routinely used in, say, a primary care setting or in an acute hospital setting. So this chart is pretty useful to help us to determine whenever we are called on a consultation as to whether a patient, say, who has a penicillin allergy is suitable or safe enough to try another cephalosporin, and if another cephalosporin, then what are the options, be it intravenous preparations or oral preparations. So in this paper also, there is a pretty good timeline which describes to you what happens when the patient acquires a label of a drug allergy. So if we move from the left to the right, about 75% of penicillin allergy labels are acquired by childhood, unfortunately. And even though most labels are inaccurate, these labels do carry on over time. And up to about 25% of adults with a penicillin allergy label have that label which persists, even though most of them are possibly not truly allergic. And we also know that some of these allergic reactions do fade over time. So the label becomes a greater liability than the risk of a reaction, only for the simple reason that once the label stays, nobody will remove the label for various reasons. Firstly, because the patients may be unwilling to have that label removed. Secondly, there is always some degree of medical, legal liability or culpability should that label be removed and then subsequently the patient develops a reaction again. So then what happens is that there is pressure to prescribe second and third line antimicrobials, leading to inappropriate use of antibiotics, increased mortality and risk, in particular for complicated infections, where the appropriate antimicrobial therapy is discarded and is then deemed to be not suitable, thus increasing the risk of treatment failures as well as risks of infections, which then become multi-drug resistance. And of course, what then this translates into will be a longer length of stay in hospital and higher healthcare costs. So what about the converse, which is to test and remove unnecessary drug allergy labels? Well, we do know that this can be a pretty cost-effective measure. Patients then become reassured that they are safe enough to continue or to restart taking the drug which they had been deemed allergic to for the last 2 to 3 decades or so. Expenses are reduced because most of these drugs are much cheaper. And also there is an avoidance of bad outcomes, for example, treatment failure, surgical infections, multi-drug resistance. But there are certain caveats about unlabeling, which we will talk about later on in this talk. So why delabel? Antibiotic allergy labels are reported, if you look at the literature, in up to about 20% of hospitalized patients. Yet, if you do a systematic allergy test on these patients, you will find that about 85% of them will be negative after formal testing. So among critically ill patients, up to about 25% of patients in acute care units, including intensive care units, will tend to have an antibiotic allergy label. And up to about 12% of patients in the emergency departments and about 10% in the ICU have a label of a penicillin antibiotic drug allergy. So AALs do lead to the prescription of antibiotics that diverge from guidelines, and there is thus an increased risk of antibiotic resistance, mortality, and in particular in patients who are important. What does inappropriate, a higher risk of Clostridium difficile labeling lead to? It leads to infections because you do use second line, third line, broad spectrum antibiotics, which increases the risk of C. difficile. You end up with antimicrobial resistance, like for example, methicillin resistant Staph aureus, or even vancomycin resistant Enterococcus. And I think one of the most feared would be multi-drug resistant granin, which then do not respond to your conventional, because these can treat selective antibiotics. So they are fair to the critically ill patients. So if you look at the costs of broad spectrum antibiotics, like say the carbapenems, we do know that the prescription costs are about 30 to 40% higher, in particular in patients with suspected penicillin allergy. And in about half of children with reported penicillin allergy in this study, which was published in the Annals of Allergy, so presented children the estimated annual savings which exceed $34 million. And I think one of the reasons for these is because all the newer generations, third, fourth generation cephalosporins, do tend to be the branded originator cephalosporins. Whereas if you compare to the first generation drugs and the beta-lactam penicillins, most of these drugs go generic after a couple of years or decades. And so the price of the drug does drop over time. So if you look about cost savings of removing penicillin allergy label, it amounts to about $1,300. You can have a cost avoidance of about $1,800. And the potential cost savings in this study in the pediatric emergency department population was up to about $200,000. And if you look at many of the other studies, a lot of the other studies, in particular from the United States, have shown fairly significant cost savings. You actually delabel systematically patients who have been inaccurately labeled with a diagnosis of penicillin allergy, because then you end up using the conventional standard antibiotics rather than using fairly expensive broad spectrums. So there are a few studies arising from Australia and New Zealand, which has shown the success of what we call the multidisciplinary antimicrobial stewardship programs. So this was one of the earlier studies, again reported in an infectious diseases journal, of a program in Melbourne, Australia, where this was an integrated antibiotic allergy testing antimicrobial stewardship program, which was a multidisciplinary collaboration among infectious disease physicians, allergy respiratory physicians, pharmacists, as well as a dedicated antibiotic microbial stewardship program pharmacist and physician. And in this program, they managed to delabel an antibiotic allergy in up to about 83% of patients. And eventually, all the inaccurate antibiotic allergy labels were removed in about 56% of individuals. And what this program led to was that after adjusting for the indication for giving the antibiotic, the comorbidity index, and in the care setting, they found that patients then ended up receiving narrower spectrum antibiotics, in particular penicillins and beta-lactams. Antibiotics were more appropriately used, and there was less likely use of the restricted antibiotics, like, for example, carbapenems, as well as the third, fourth generation cephalosporins. A similar study from Auckland, New Zealand showed that up to about 80% of patients in their cohort could be delabeled. And what's important is what happened during the delabeling process. So 80% of patients in this study were successfully delabeled even after a fairly simple exercise like an interview by a pharmacist who had been trained in the delabeling process. For some of those patients who had a little bit more of a dubious history, about 16% of them had an uneventful orange challenge eventually, and 4% of them were deemed to be inappropriately labeled after they were referred to an immunology clinic and then subsequently evaluated and tested. So in this cohort, only about 20% of patients, by and large, were so-called appropriately labeled. So what happens then is that when you change the inpatient antibiotic therapy in up to about 60% of these delabeled patients, they found that there were no adverse reactions even after commencing these patients on penicillins. And at 1 year of follow-up, up to about 98% of patients who were delabeled had no adverse reaction after they repeated administration of penicillin antibiotics. And I think these are the kinds of results which are again demonstrated in many of those studies on drug allergy labels, drug provocation tests, which have originated from Europe, in particular from the ENDA work groups. One other study from Melbourne, Australia, which showed, again, the similar kind of success story, where they were able to demonstrate a fairly high rate of penicillin allergy delabeling in patients who were referred subsequently for an inpatient oral challenge. And the success rate was up to about 95%, and patients had their penicillin antibiotic allergy label removed. And for the 22 patients with the type A reactions, which are the non-hypersensitivity reactions, 63% of them had their penicillin antibiotic allergy label removed. And so what subsequently this program showed was that there was a significant decrease in the prescription of restricted antibiotics, third, fourth generation cephalosporins, fluoroquinolones, carbapenems, pip-tazo, and linezolid. And this just goes to show that these programs, if properly run, can be fairly successful in a well-constructed type program setting. So then what are the challenges with delabeling if delabeling seems to be something which seems to be fairly successful? I think some of the problems we as allergists face would be firstly that of a very vague history of the index reaction, which often has occurred years or even decades ago. And the reason why the index reaction is important is because it impacts on how we risk stratify this patient. And it also impacts on the types of tests that we offer. So say, for example, if a patient has a history of what is pretty consistent as an NSAID hypersensitivity reaction, except the patient is unable to tell you which particular NSAID they're hypersensitive to, without knowing what happened during the index reaction. And then subsequently, say, for example, doing a in vivo or in vitro test, like, for example, a skin test, having a skin test negative in an NSAID hypersensitivity reaction is not unexpected because most of these reactions are cross-reactive. So if patients are unable to articulate what the index reaction is, then it's possible that you might be offering the wrong test to the patient. And at the end of the day, the result may be inconclusive. The test may be falsely negative, but then you might end up doing a drug provocation test, and a drug provocation test may end up positive. So if the patient had, like in this day and age, been able to document the history properly, like in their blog or some other online media, or in fact nowadays what we do is we see a lot of the younger patients in particular who for some strange reason like to take pictures of their reactions. They take selfies of their particular adverse drug reactions. Most people would keep this on their phone and show it to their doctor, but there are of course some people who decide to post it or on social media platforms. So in a way, that can be a good thing because at least it helps document what exactly happened, and there is objective evidence of what happened during the index reaction. The other thing about the challenges that we face is that the adverse drug reactions sometimes are not clearly differentiated from the drug hypersensitivity reaction. So for instance, if on the electronic medical record, a record of say erythromycin appears, but there are no details of what exactly that index reaction was, it makes a very big difference whether that erythromycin reaction was an urticaria angioedema type reaction or whether that erythromycin reaction was just dyspepsia or epigastric pain, which is a known side effect of macrolide antibiotics. So that brings us to the third problem, which is the historical documentation, which is often without a description of what the index reaction would look like, even in medical records. So if you talk about paper documentations from childhood, it's usually quite vague. The documentation usually doesn't tell you whether this was more likely to be a viral exanthem or whether it was drug-induced. And it doesn't help that usually 2 or 3 different classes of drugs are given at the same time. Okay, sometimes perhaps to allay very anxious parents who do not know why the children are not getting better. The second problem which electronic medical records has brought is that sometimes these labels and drug alerts appear on the electronic medical records. And I think there are usually quite a lot of medical legal concerns on what should potentially happen if you erroneously remove that electronic medical record of that particular drug alert. So I think with the ongoing digital transformations and the improvements in electronic medical records, nowadays there are ways to ensure that when electronic medical records are updated or a drug alert is removed, there are processes to ensure that there is a way of tracking back to who did the removal and the reasons why the removal was done. So say, for instance, if the patient who was labeled as being allergic to a medicine subsequently was inadvertently given a course of the medication again and nothing happened, then I think it is pretty safe to remove that so-called drug allergy label. Okay, the fourth problem would be negative predictive values of negative provocation tests. So there are various protocols that are now internationally published for various different types of drugs and the various types of provocation tests. And I think recently, and this year, there is literature which has come from Pascal group, which has looked in particular at the drug provocation test regimes for NSAID hypersensitivity in particular. But in the field of antibiotics, things are probably a little bit more complicated. So should the patient be challenged to a single dose of the drug? Or should it be a single daily dose? Or should it be a full course, a 5-day course of the drug? And there is always this concern that even if the patient were to tolerate that particular single dose or single day drug provocation test, is there a risk that we are sensitizing these patients now to developing new de novo hypersensitivity drug reactions towards the end of the course of that challenge or with subsequent causes of the medications? So the fifth problem is when you're faced with certain situations where you do need to decide whether this drug allergy label was truly real or not, and whether these patients should be rechallenged. So in particular, when we're talking about critically ill patients in ICU, for instance, where it is not the most ideal to conduct a drug provocation test, in particular when patients are hemodynamically stable and when there are end organ impairments. And in children, there is this other question of cofactor, which may sometimes be present or absent during the provocation test. So we do know that in certain drugs, for instance, the infection may be a cofactor which is necessary for a reaction to occur. But if you were to challenge the patient in the absence of that cofactor, you may get a negative a drug provocation test. But if the patient then subsequently develops an infection again, the presence of that cofactor may again trigger the reaction. And I think, at least in our experience, we do see that in particular in children who react to paracetamol or the NSAIDs, or even sometimes in young adults as well, they will tend to give this history that sometimes when they take the particular NSAID to a certain dose for, say, a headache or, say, for a musculoskeletal pain, they are able to tolerate it, but when they take it for febrile reaction or upper respiratory tract infection, they get the symptoms coming back on again. So then what do you do with patients who are like that, who need that particular cofactor? So lastly would be the medical legal implications. If you look at a lot of these delabeling programs, a lot of these delabeling programs also involve a pharmacist or a practice nurse who is involved in the particular program or project. So would it be safe for a pharmacist or a nurse-led program who assesses a slightly lower risk patient to delabel, or should all cases have to go through an allergist, meaning to say the allergist needs to see the patient, in particular the higher risk patients, before the delabeling can occur? So there are a lot of all these factors which do need to be considered before we start any delabeling program or before we even delabel a patient who has been labeled with a possibly untrue drug allergy label. So this is pretty important, the risk-benefit assessment. So you do need to risk stratify your patients to the high risk and the low risk. So if you look at the high risk reaction, those are really truly based on the index reaction. So if patients can remember the reaction, if there is proper documentation of the reaction, then that really makes things much easier. So usually the severe reactions are fairly well documented. Skin peeling, blisters, or a severe delayed reaction, or even features of, say, anaphylaxis like facial swelling, breathlessness, lip swelling, wheezing, throat swelling, a drop in blood pressure. These would be the high risk reactions and the high risk drugs where one would need to be extremely careful before deciding whether it is safe to delabel the patient or not. So the lower risk ones, for example, are rash, itching, abdominal pain, vomiting, or the other one, which is an asymptomatic patient, but the patient has a family history of drug allergy, say to allopurinol or to, say, penicillin, and so the patient has himself labeled himself or herself as being allergic to the same medication. That usually would be slightly lower risk or fairly non-specific symptoms, which may mimic the original condition that the patient has, for instance, migraine or a respiratory tract infection. So the risk-benefit assessment is extremely crucial and really has to be based on the history of the index reaction. And so how should we delabel? So in the analysis of delabeling, other than the index reaction, we do need to decide whether this is an immune-mediated reaction or a non-immune-mediated reaction, whether it's IgE or non-IgE involved. If there are fairly validated in vitro or in vivo tests, for example, specific IgE tests or skin tests, patch tests, intradermal tests with delayed reading, then these tests should be offered first or considered first before going onto a drug provocation test. In particular, if either a single in vivo or in vitro test is negative or combinations of the tests are negative. Sometimes, like for example, for non-steroidal anti-inflammatory drugs, you would just need to proceed to a drug provocation test directly because most of these reactions are not IgE mediated, and so the cellular tests, the in vitro, in vivo tests would not be relevant in this case. But bear in mind, with every drug provocation test, there is also a little bit of a risk. So the oral direct challenge should only be for patients with fairly low risk. So this is a pretty busy chart, which basically just goes back to what we've been talking a lot about all this while. And that is that the history of the reaction is the most important. From there, then you need to classify the patients into whether they're high risk or low risk. If they are fairly high risk, then you would think of various other in vivo and in vitro tests to do. If they are pretty low risk, then there is a possibility of going directly to an oral challenge. But as with all oral challenges, drug provocation tests, it's very important to again risk stratify that patient and consider also the patient's comorbidities, in particular, whether the patient is young, elderly, whether the patient has other comorbidities, like for example, asthma. If there is asthma, it needs to be well controlled. If there is heart disease, that needs to be well controlled before you proceed to do the oral challenge. And there would also be cases where the testing is absolutely not recommended. So for example, patients who have definite features of SJS, TEN, it usually would be more prudent to just use an alternative drug rather than those which had been suspected during the index reaction. So this just gives you a close-up of the earlier chart, which shows you what to do, how to tier the skin test, and how to decide what to do depending on whether the skin test is positive or negative. So again, the basic principle is that negative skin tests should be followed up by a graded oral challenge. In certain situations, you can proceed directly to an oral challenge, and then you can subsequently delabel. There may be a need for a slightly more prolonged oral challenge. So in particular for antibiotics, I think most of the groups which do oral challenges do tend to give a course of the antibiotic rather than just a single dose or a single daily dose. So this is also a nice review published last year, which shows the algorithm, which is pretty similar to the previous slides. But in this case, this algorithm is more for penicillin adverse drug reactions or allergic reactions, in particular in ICU patients. And if you look at the structure, it's fairly similar. The most important part is this part here, which is to address what the allergy phenotype is, and then to risk stratify whether the patient is high risk or low risk. And then the subsequent algorithms would be all the same. So this is a close-up of the bottom part of that table. So if it's low risk, you can consider either a direct challenge, or you could even consider a test dose depending on the situation. If it's a high-risk patient, then if time permits, then always consider skin tests before oral challenges, in particular in the setting of beta-lactam penicillins, which is what this chart is meant to show. If there is any doubt, what we usually tell our various colleagues and other specialists is that if there is any doubt, always refer to the allergist for a thorough evaluation. Because there are medical legal implications usually, in particular in the critically ill patient who is ventilated, who is on an inotrope in the ICU, and the last thing you want is to do a test which is clinically inappropriate or not done properly, and then end up with more potential problems, in particular in a patient who is already hemodynamically unwell. So what are the so-called paradoxical outcomes of delabeling? One would expect that if you delabel a patient, the patient would then be reassured, and happily the patient will subsequently take the medicine with little fear of recurrence of an adverse reaction. But the paradox is that sometimes you'll find that despite safe tolerance of the drug, there will be patients, or even their physicians, or even the parents who remain reluctant to use the drug. In particular, there are quite a number of studies on penicillin allergy delabeling. And I think there's sometimes a fear that even if the reaction had been deemed safe and the person had passed the skin test and the drug provocation test, there's always this concern that an allergic reaction could potentially happen again. The second problem is that sometimes after delabeling, after spending hours and days arranging the drug provocation tests and having the patient pass the test, patients continue to retain that penicillin allergy label despite the negative test results. And worse still is that sometimes patients become relabeled as having a penicillin allergy again after testing, despite no new history of the adverse event. So I think as long as we bear in mind the safety issues in delabeling, things should be fairly safe. So when we talk about desensitization, there is always sometimes a little bit of confusion between what exactly is a drug provocation versus what exactly is a desensitization. So this is just to remind ourselves that desensitization is a therapeutic process, and it is a state of inducing temporary tolerance to a drug. So for example, in aspirin desensitization for coronary artery disease, in antimicrobial desensitization, or in desensitizing patients who develop hypersensitivity reactions to biologics and chemotherapeutic agents. Now, the most important thing in desensitization is that because it is a state of temporary tolerance that you have induced, the drug allergy label should not be removed. So sometimes what happens is that patients who are successfully desensitized have the aspirin label removed. And if the patients then stop the aspirin for, say, about a week because of, say, upper gastrointestinal bleed, other practitioners may not realize that the patient had previously been on the desensitization, and they inadvertently just restart the patient on the full dose of the aspirin again. So that's the reason why it's important to bear in mind that patients who are desensitized should continue to have the drug allergy alert in their medical record. And at least in our practice, what we do is that we do have certain ways to ensure that on the electronic record, it is labeled that the patient is on a desensitization. And so that's the reason why the drug allergy label continues to remain on the system. So what about this phenotype called the multiple drug hypersensitivity or intolerance or allergy patient? These patients are rare, but they do exist. So it's very important to take a very careful history and review all the available medical records that are available for patients who come to us with a list of 5 to 10 drugs that they are deemed allergic to. Because sometimes you'll find that in these 5 to 10 drugs, there may be patterns of reactions which may suggest that these are just multiple NSAID reactors, and the patients develop the same phenotypic reaction each time: urticaria, angioedema, bronchospasm. But if there are patterns where, say, there are certain high-risk drugs on the list, for example, beta-lactams, cotrimoxazole, versus fairly low-risk antibiotics, say, for example, metronidazole, then it also helps us to assess at the end of the day which of the drug reactions are likely to be real and which of the others may be either coincidental, maybe due to the underlying condition that the patient has, or may just have been an adverse drug reaction. So, for example, like say a change of taste with the drug or epigastric pain with the drug. This is probably the most important: prevention of future mislabeling. So the physician education is probably the most important of it, and that involves making a correct diagnosis and labeling at the onset during the index reaction. Subsequently, we also do need to educate physicians to practice safe, discriminate, and appropriate prescribing, especially antibiotics. So not just the physician, but the patient himself or herself does also have a role to play. So we do need to encourage our patients to avoid self-labeling without clinical verification of what the index reaction was. The drug allergy alert card or the drug allergy passport is key, because from there we can then reevaluate the likelihood of the reactions to the drugs which the patients had been implicated to not be able to tolerate. And last but not least, electronic medical records with back-end clinical decision support systems and other innovative healthcare delivery methods. So say, for example, certain digital platforms which the patients can refer to would be very crucial to prevent future mislabeling and accurate labeling of drug allergy adverse drug reactions in our patients. So in conclusion, for any delabeling program to be successful, I think we do need to target both the patients and the physicians. In particular, for younger children, parents, delabeling efforts are important sometimes because we don't want to have drug allergy labels carry over into adulthood, especially when the adults turn 60s, 70s, and really no one has any clue then what exactly happened like 30, 40 years ago. Before we carry out any delabeling process, we do need to think about the risk benefits of delabeling. And I think to non-allergists, sometimes our colleagues do not realize how much effort it takes in delabeling a patient, how much effort it takes in organizing a skin test and a drug provocation test, especially during these COVID times, pandemic times, where there is safe distancing, where you need to ensure that your clinics are not filled with too many patients undergoing various types of procedures. I think it's pretty important for us to recognize the fact that there are resource constraints for lots of allergy procedures. And so there is a need to risk stratify the patients and to prioritize the patients so that those who really need to be delabeled first should go first. There are certain low-risk strategies, for example, direct amoxicillin oral challenges, which can be done in the fairly low-risk patients. And I think what's the most important is that we need to integrate our penicillin allergy management, antimicrobial stewardship programs into a consolidated outpatient and inpatient program where information can flow not just through the patient and the family members, but also through our electronic medical records, which with clinical decision supports at the back end, so that if a patient is, say, correctly labeled as being allergic to an antibiotic, there is some form of clinical decision support at the back end, which prevents the prescriber from inadvertently prescribing the same antibiotic or the same drug or a potentially cross-reactive drug, which then may result in adverse outcomes. Thank you very much.
Thank you very much, Professor Thong, for the excellent lecture. I'd like to now invite Professor Demoli and Professor Thong to have a discussion and have questions to each other, as well as important questions related to these topics.
If I may start for Bernard, whom talk I really appreciated. I mean, delabeling is easy for us allergists, and I think the major issue of delabeling is for non-allergists, is the way how we transfer our technology to our non-allergist colleagues. And also, I do think that it needs to be a general politic of a nation, because the examples that you showed are examples of rather medium-sized hospitals and with good leaders able to bring everybody together. But how about at the level of the whole country for non-allergists?
Wow, that's a very big order. Even in our practice, we are dealing with just trying to educate not just our colleagues but our infectious diseases physicians also. I think if you talk about, say, at a regional or a national level, I suppose it's important for patients in particular and physicians to understand the importance of delabeling. I think what happens out in the community is that people are not very aware of the importance of delabeling, and in fact, because if you look across the various therapeutic classes of drugs nowadays, there are so many alternative drugs. So to the patients, they will think that, oh, if there are so many alternative drugs which are not that expensive anyway, why don't I just take an alternative rather than to go through this entire process of delabeling? So I think that's one, the mindset's important. And usually we find that the patients only end up with problems usually in their later years, when they're their 50s or 60s, when they find that they have run out of drugs to use, run out of antibiotics to use, and then that's where the problem comes in. In certain parts of Asia, in Singapore, for example, one of the other problems we face is because of the way the healthcare financing system goes. So the problem is that, well, in a way, the problem is that our healthcare system is a co-payment system. So meaning to say that if the patients were to come in for, say, a procedure, a delabeling, an allergy consult, the patients do need to pay on their own. And then depending on whether they're insurance paid or whether they are what we call the patients, some patients do get some proportion of subsidies. But because there's co-payment, so there's always this need to have some out-of-pocket expenses of your own. So sometimes this becomes a little bit of a disincentive for patients to delabel themselves too. So I think in various countries, the problems that are faced are slightly different. And of course, the third thing would be whether there's an allergy community out there, allergists, immunologists who are able to front this delabeling type of programs and to be able to work closely with their other physicians and their internal medicine specialists. In fact, in particular, the ID physicians. What about in Europe? What are the challenges that you all face there? I know in Australasia things may be a little bit different, as you mentioned earlier on.
Yeah, there is no politic regarding delabeling in Europe, as far as I am aware of. For my country, France, there is none. I have been pushing the health authorities to understand that wrong labeling is actually partly responsible for antibiotic resistance.
Yes, you're right.
There are politics. There are programs to fight. There are national programs to fight against antibiotic resistance, and I think that we allergists have here a good opportunity to fit into those programs, because one of the paper that you showed, the one from Kim Blumenthal, when she showed that I think 50% of the Staphylococcus resistant patients are actually labeled as penicillin allergic.
Yeah.
And something like 15 or 20% of the Clostridium difficile infected patients are labeled beta-lactam allergic. So if we can convince our politicians that false labeling is actually responsible for part of the antibiotic resistance, that could be included in those national programs, and also that could be covered by Social Security, because in the end, it is a public health issue.
Correct. Yeah, I agree with you. So even in Singapore, at the Ministry of Health level, we also do have these antibiotic resistance programs from the various hospitals, looking at multi-drug resistant antibiotic organisms, VRE, for instance. But you're right that, well, I think as allergists, we haven't been very active in that domain. But the good thing is that we currently have infectious disease physicians who are interested in this. So you're right that I think the partnership is important, because that's the only way in which governments will be a little bit more proactive, a little bit more supportive for such programs.
And one trick which I'm trying to do in my hospital is to be part of the antibiotic stewardship team.
Right.
Because you have antibiotic stewardship teams in all hospitals. It has now become almost mandatory because it's too complicated for non-infectious disease doctors. And instead of asking us specific questions from time to time, one way would be to be part of the team.
Yeah. So that's what we started to do end of last year. So our infectious diseases antibiotic stewardship team got us on board to design a beta-lactam allergy evaluation service. Unfortunately, that got halted somewhere in February because of COVID. So we've just started to re-energize the program and bring the program forward again. But you're right, I think we need to work hand in hand, because that's the only way. Then that's when the infectious diseases physicians will be a little bit more convinced.
Yeah. Well, of course, beta-lactam delabeling is the topic, the hot topic. But I think delabeling of any drug allergy is interesting as well, because if I go back to my own topic, I don't know if people realize what are the consequences of being labeled NSAID allergic.
Yeah.
And you and I know exactly what it is. If you talk to anesthetists, they tell us that it's almost impossible to operate someone that is labeled allergic to NSAIDs, because that's the level 1 anti-pain. reliever. So there is a need for delabeling most of the important drugs. Of course, first beta-lactam, second NSAIDs, and maybe others.
So the NSAID question is interesting because we see it across all age groups in Singapore. So because we've been pretty we've been quite proactive, let's put it this way, in educating the physicians as well as the public on NSAID sensitivity. So there's lots more interest in that now. So I mean, as you probably know, we've been doing a lot of challenges, maybe for the last 10 years or so, but ours is a little bit different. Rather than do a challenge to confirm the reaction, we usually end up doing more COX-2 challenges. The reason why we do it like that in Singapore is because by the time the patients come to us, they would have reacted to at least 2 or 3 different NSAIDs already, and they've kind of given up. So we just give them an alternative to use. And the slight advantage recently is that the selective COX-2 inhibitors have gone generic in Singapore, so the price has dropped compared to the originator drug in the last 5 to 10 years or so. But one question that we face in some of our patients is that some of our patients do have this cofactor which is associated with the NSAID hypersensitivity. I don't know how often you see that in your practice, where, as I mentioned earlier on, during the febrile reaction, they get the reaction, but after that, they don't get it. So they don't know whether they should take paracetamol or not. What do you do in situations like this?
I suppose you're talking about exercise or food or alcohol in the case of NSAID. You are right. I think we don't have big series to have strong recommendations in this regard. If there is a clear cofactor like exercise, food, or sun exposure, I would test that. For example, we will do photo patch test. We would do exercise or food challenge, and then the NSAID challenge in order to push the system. But you and I know very well that in the lab, in the clinic, most of the time we are not able to reproduce the exercise, food, NSAID hypersensitivity. So it's a very difficult question that would need more data, I would say. But regarding infection as a cofactor, as you said, for antibiotic, I do think that the immunological background is still lacking. I still carry on saying that if my drug provocation test is negative, the patient can safely take the drug, although I know that once in a while, one will have those 2 factors needed in order to have a reaction. But I would say that it's such a minority of patients that I wouldn't generalize. You know, it's difficult to give a very safe message to our patient. If what you said is correct, we can do the full thing, and in the end, they won't take the drug because they still think they are allergic. If we start putting the idea that there may be not such a good negative predictive value, they won't do it.
Yeah, correct. Yeah, absolutely agree with you.
So that's the way. I'm not 100%. I don't give 100% the truth to my patients, and but I have my reasons, and I think I'm okay with that.
I think it's also probably depending on the patient's ability to handle the risk. I realize that for some patients, they are a little bit more risk averse, whereas for some, they wouldn't mind because they know that it's a controlled situation during a challenge. So if anything happens, you know, they're pretty okay with it.
Yeah, I agree. I mean, the patient we can work on. The worst is the referring doctor. Sometimes we have general practitioners referring for drug allergy workup. We prove that the drug is not responsible, and they still do not prescribe it. telling the patient that, you know, allergists, they are not always sure about what they're doing. And this is terrible.
Ours is the converse. Ours is they will refer and they will follow generally what we say. I suppose it's a bit of selection bias because if they didn't believe it, they wouldn't refer. At least that's what happens in Singapore.
Okay, maybe it's the French way of thinking. Regarding the patient, we are now evaluating an electronic card that is based on the blockchain technology.
Ah, right,
so
okay.
We are starting a program on that. Therefore, whenever a physician sees something or a patient sees something, it is written in the system, but using the blockchain signature, so that none of the things can be erased or modified. Right. And so we have developed that within a small startup company that we are working on here, and we're trying to validate that in order to help to put the patient in the center of the decision, right, and help this whole thing about drug allergy, delabeling and labeling.
Right. So what we have now is from our public hospital, public healthcare system, electronic medical record, the drug allergy alerts and the labels are pushed out on the back end to a app called Health Hub. So Health Hub is an application which all Singapore citizens, permanent residents have access to. And what you do is when you download this application called Health Hub, it gives you your entire medical records, your vaccination history, your drug history, including your drug alerts. So what we do is we use this as the central primary source of truth, and we hope that patients then use this to help to navigate the healthcare system and also to monitor their own healthcare. So recently, in the last, I think, month or so, what's happened with Health Hub is that we've also the system has been such that it has allowed, say, elderly patients to allow one of their caregivers to have access to the information too. So you have to assign a particular health caregiver, and that caregiver will be able to, help you to navigate your records, look at your records and things like that. So that's what we've been doing here. Yeah.
It's excellent, but we all know that Singapore is very much advanced in electronic health record, which most of the countries haven't reached the level of Singapore.
That's because we're small. That's the difference.
Thank you very much.
That was really an excellent discussion. I had a question actually for both of you. I mean, occasionally you come across patients who have a reaction to a vaccination. So flu vaccine. So, I mean, what we do is we try to do the skin testing using the same lot. But what would you do in a proper systematic way to evaluate that? And what would you do? Would you allow the patient to have a flu shot in the following year? What would you give some antihistamine prior to giving the flu shot? How would you evaluate?
I can start, and Bernard will carry on. First, I check if the patient is immunized. If there are IgG available against the different infectious disease, I would check that first to be sure that the patient is not protected, because most of the reactions are so-called hyperimmune reactions. So if the patient is not protected and if the reaction is not too severe, I would do, most of the time, I would split the vaccine and vaccine immediately. We know from big series that we can vaccine immediately without pricking, without splitting the different dose. But basically, I will never, ever issue a certificate of contraindication. I'm very pro-vaccination, so every single patient that comes to my clinic thinking that he or she will get a certificate for no vaccination will actually be vaccinated, because even if you start with pricking or intradermal, you actually vaccinate the patient. So
that's correct.
Bernard?
Bernard?
Yeah, So usually in Singapore, if you're talking about influenza vaccination per se, right? So usually influenza vaccination for the concerned patients, we just bring them in and we split the dose, as Pascal said. It's more or less like an incremental dose challenge, and most of them do tolerate it. I suppose in children, it's a little bit more tricky because you need to deal with the parents here more than the child.
It's true.
I mean, we do also split the dose, but I'm just asking is that if you develop a reaction to it, a skin reaction to it, which may not be very severe, but a skin reaction, the mother's concerned about it. How do you deal with it when you have to give the next flu shot?
If I may, I try to avoid a skin test because there are a lot of false positives. So if I do a skin test, would be a micro prick, something very tiny, because it's small volumes. Usually it's 0.5 milliliters. So it's difficult to lose some of the vaccine under the skin. And remember, the needle is sealed to the syringe, so it's difficult to make a dilution, and it's not appropriate to empty the syringe in another tube. So using the same, I might do a small prick and see, okay, you have nothing, and I can put 0.1 milliliter on one arm, and an hour later, 0.4 milliliter on the other arm.
Thank you. Bernard, any comments?
Yeah, so usually, so particularly in adults, because we don't deal with so many children. So adults, I think for influenza vaccinations, it's quite well known that at least in Singapore, with subsequent vaccinations, you do tend to get local reactions with the different batches. So what we do is we just tell them that if you've had a local reaction in the past, this time just be prepared for one, and just the usual topical measures, just compress, take paracetamol if needed, and most times most patients are okay.
Okay, thank you very much. I express my deepest gratitude to Professor Delabeling and Professor Thong for this excellent talks and for the really informative and very interactive and something that our member society would be extremely grateful. We'll have your lectures up soon, and in combination with Mariana Castells too. This has been an excellent session on dry hypersensitivity. So thank you very much, and a good evening to you.